Thank you for joining us today. I want to welcome everyone to the next in STS's summer series of webinars. This series runs every other week and features presentations and panel discussions on a variety of topics relevant and important to CT surgeons and the world of CT surgery. STS would like to thank Medtronic for their generous support and sponsorship of this webinar and the STS summer series. Today's topic is pulmonary metastasectomy. Still recommended? We want to make this webinar as interactive as possible and hear from you, the audience. To this end, you may enter questions through the Q&A feature in Zoom. The panelists will try to respond to as many questions as possible. Please note, this webinar is being recorded and will be available tomorrow morning on the STS website, STS YouTube channel, and the STS Surgical Hot Topics podcast. At this time, I am pleased to welcome our moderators for this session, Dr. Bernard Park and Dr. Dirk van Raemdonck. Dr. Park is a thoracic surgeon at Memorial Sloan Kettering Cancer Center in New York, and Dr. van Raemdonck is a professor of thoracic surgery at University Hospitals Leuven in Belgium. Dr. Park, Dr. van Raemdonck, I'll now turn it over to you.
Thank you so much, Wes. And thank you to the STS and to my co-moderator, Dirk, for wonderful planning of this very important session. I'm going to turn it over to Dirk to go over the goals of the webinar, but before I do that, I just wanted to thank and introduce our esteemed panelists, starting with Dr. Mara Antonoff, thoracic surgeon and assistant professor of surgery at the MD Anderson Cancer Center in Houston, Texas. Dr. Frank Detterbeck, Chief of Thoracic Surgery and Surgical Director of Thoracic Oncology at Yale University in New Haven. Dr. Michael Lanuti, Director of Thoracic Oncology at the Massachusetts General Hospital in Boston. Dr. Andreas Rimner, Radiation Oncologist at Memorial Sloan Kettering Cancer Center in New York. And Stephen Solomon, Chief of Interventional Radiology at Memorial Sloan Kettering Cancer Center in New York. I really thank all of the panelists for taking the time to address this important topic. So now I'll turn it over to Dirk. He's going to go over the goals of the webinar.
Thank you, Dr. Park. Also on my behalf, welcome to this summer webinar on a very interesting topic. So actually the goals of this webinar are threefold. First of all, we want to review the recent STS expert consensus guidelines on pulmonary metastasectomy that was published last year in the Annals of Thoracic Surgery. And actually two of our panelists were co-authors on this paper, Dr. Michael Lanuti and Dr. Frank Detterbeck. So we are very happy to have them here on this webinar this evening. Secondly, we want to discuss the role of local therapy in the multidisciplinary treatment of pulmonary metastatic disease. And finally, we want to compare all the available ablative modalities such as surgery, stereotactic ablative radiotherapy, and other forms of ablation, and how to choose between these different modalities. So I now turn over back to Dr. Bernie Park to give us some demonstrative cases on pulmonary metastasectomy. Bernie?
Thank you, Dirk. So I picked a few cases submitted by some of our panelists to demonstrate some clinical, real clinical cases and some of the types of scenarios that all of the panelists and all of you that are joining us in the webinar often face. First case is that of a 52-year-old with a history of metastatic osteosarcoma that has pulmonary metastases. The patient was initially diagnosed in 2002 and at the time underwent resection and adjuvant chemotherapy, was free of disease until 2005 when they were diagnosed with pulmonary nodules, and at that time underwent bilateral VATS and wedge resections of all known disease. Again, was free of disease for 4 years when there was a left lower lobe nodule that was detected. So you can see that actually if you go back between these x-rays, probably the nodule was there a long time, but probably not really becoming realized until December 2008. And slowly over time, 7 months later, had some growth, and 5 months after that, had some additional growth. So really now 7 years later and 4 years after initial metastasectomy with a solitary growing nodule. So what would you recommend in this scenario? Continued observation, surgical resection, radiofrequency ablation, stereotactic body radiotherapy, or systemic therapy, chemotherapy? The next case is that of a 83-year-old with a history of metastatic cholangiocarcinoma. Initial diagnosis in this patient was in July of 2016, and the patient underwent a laparoscopic liver resection with complete resection and had no additional therapy for isolated disease. Was NED until 2 years later when a new left lower lobe nodule was identified and a biopsy was actually done, positive for metastatic cholangiocarcinoma. Had no treatment, just had observation for almost 2 years when there was a question of liver recurrence. Patient underwent, without tissue diagnosis of the liver, 1 dose of systemic therapy, which they did not tolerate. Had a repeat liver MRI, which showed no tumor, and yet had this continue to grow lesion here in the left lower lobe, isolated. So what do you recommend for this patient? More observation, surgical resection of the pulmonary disease, radiofrequency ablation, radiation, or systemic therapy? And the last demonstrative case is that of a 77-year-old with a history of breast cancer in the distant past and metastatic colon cancer to a growing right lung nodule. Patient's colon cancer was diagnosed in February of 17. Initial path was stage 3B after lap right colon. An adjuvant treatment was NED for almost 2 years when diagnosed with liver metastases, underwent liver resection and hepatic pump therapy. In October of 2019, developed a punctate right lung nodule and underwent chemotherapy for the remainder of 2019 into 2020, and then observation. And as you can see, punctate lesion in October 19, which has been steadily growing both on systemic therapy and off systemic therapy with no additional nodules. So again, what's the recommendation in this patient? Would it be observation, resumption of chemotherapy, surgical resection, ablation, or radiation therapy? Of note, this patient has no tissue diagnosis. So I just showed some common cases. I tried not to complicate things by having patients that had multiple lesions. So I just kept it simple, one lung lesion each patient. And so I thought that these were all somewhat different cases, but had some common themes to it, and thought it would be a nice springboard towards the further discussion in the webinar. So with that, I'll turn it back over to Dr. Van Raemdonck, who will now take us to the next section.
Thank you, Dr. Park. So actually the first topic for our discussion is on the STS expert consensus document. And we have prepared some questions for our co-authors on that paper. So maybe the first question is to Michael Lanuti. Michael, can you describe the impetus and process behind this recently published STS consensus guidelines?
Yes, hi, thanks, Dirk. So the guideline was a process that took actually about almost 3 years, and it was in recognition of the fact that there was no standardization of how to address pulmonary metastasectomy. At the time, there was no randomized study. The pulmic trial was not published. And so given the void in the literature of how to approach this, the STS workforce on evidence-based surgery developed a task force of about 14 people, 14 surgeons that were to basically put this together. Again, the goal was to look at the role of resection or ablation even of pulmonary metastases, so that was included. We look back to the literature. 1990 was the cut point. We didn't go beyond that. And we ended up looking at over 500 articles. And then after putting some things together with the help of the STS, we then came up with consensus statements. We realized that there was no level 1 evidence for any randomized data to even give a frank recommendation. So we therefore, these are consensus statements, and they were subject to voting. So the panel had to vote, and they had to be a greater than 75% consensus or an agreement for them to make as a consensus statement. And if they weren't met at 75%, they were not even included in the entire manuscript. Again, these are opinion statements. These are not formal recommendations, and that's an important thing to note. So anyway, that's how it was put together. We can sort of talk about other things.
Okay.
Yeah, Mike, I would just add two things. You know, one of the impetus behind it was also the ESTS had done a nice review of metastasectomy, but you know, that was getting to be almost 10 years before. Actually, Dirk was very prominent in that effort. We thought it was time for an upgrade or update, I should say. And the other call out I'd make is just to John Handy, who led the STS project, and I think really deserves a lot of credit for putting it all together.
Okay.
Yes, thank you.
Now, Frank or Michael, can someone summarize a little bit what the major take-home messages were from your review?
Yeah, I'll jump in on that. So I think the first thing that was probably the most important thing that we could develop from this was that all these cases should be in a multidisciplinary setting, and ideally all disciplines represented that could potentially treat these patients, including medical oncology, radiation, oncology, thoracic surgeons, and even our interventional radiologists for thermal ablation techniques. So that was the one thing. The second is that I think we came to a rather easy understanding that pneumonectomy was still discouraged, but appropriate in certain cases, and so not to be completely disbanded in the select case. It was very hard to come up with a number of metastases that we could say, okay, surgeons, you can consider this. That we struggled with a lot. And as we know, the literature is all over the place. In the end, we ended up with 3 being the magic number. I don't think that any of us could give you any hard evidence that that was the real number, but 3 was the consensus opinion. And then 2 other things. So what do you do with lymph nodes, and should we do standard lymph node sampling with metastasectomy or even consider dissection? Again, very little data, lots of retrospective series. We think in the end it's really prognostic, and it doesn't improve survival. I think we all were in agreement to that. We would like to see surgeons do more sampling at the time of metastasectomy, but it's not sort of mandatory. And then lastly is that thermal ablation is part of this, clearly part of this landscape. And included, and I should say, is our radiation therapists, and you know, this notion of stereotactic ablative therapy. So those 2 are in the landscape, and particularly for patients who are high risk or who refuse resection, those are great tools in the toolbox.
Okay.
So the other thing that I would add is that, in terms of approaches, we certainly favored parenchymal sparing. Mike already talked about avoiding pneumonectomy whenever possible, but, really ideally doing a wedge or some minimal amount of parenchymal resection. The other was that, we actually favored doing minimally invasive techniques whenever possible. If that wasn't going to lend itself to complete resection, then sternotomy or, some other open approach is certainly appropriate, but minimally invasive when possible.
Okay. So maybe a final question. You already said that you have discussed a lot of questions, but what are the what are the most critical and unresolved questions that we are still living with at the moment?
Well, I guess maybe I'll jump in there. I think one of the issues, of course, is to really define how much benefit does metastasectomy really provide? The data that we have is in selected patients. It's a little bit difficult to really nail that down, the selection versus the treatment. I think another thing that is, is still difficult is how do you select patients appropriately? We talked about the number of 3, the magic number of 3, but there's more things that go into the selection, and I think that's not well defined, and I think that's why a multidisciplinary discussion, I think, is useful. Things like rate of growth, the disease-free interval, nature of the cancer, whether there's systemic therapy that's available, all of these things factor into it. And then, of course, with the advent of additional techniques like SBRT and ablation, I think how to mix and match that with surgical treatment ends up being kind of an individualized thing. And I think really defining where each of those should fit was not something that we could define very well.
Okay, well, thank you both. I'm going to turn over back to Dr. Park for the next topic.
Great. That was really a great summary. And I think we're going to delve a little bit deeper into sort of the role of local therapy for pulmonary and metastatic disease. Now, Michael and Frank mentioned that one of the key consensus recommendations is that the decisions for local pulmonary therapy be done in a multidisciplinary fashion. So my question to Mara is, what is it's easy to say that all these decisions should be made in a multidisciplinary fashion, but we kind of all are aware, both surgeons, interventional radiologists, and the radiation therapists, that many times it's kind of a one-way conversation between the medical oncologist and the local therapist. We'll just say local therapist. So how did they do it at Anderson, or how could it be reasonable? What's the ideal mechanism by which we can achieve the multidisciplinary conversation? How often do you bring in the radiation therapist or the interventional radiologist when you are referred a patient specifically for surgical management of metastatic disease?
That's a great question. And of course, this is already touched on by Dr. Detterbeck, but the multidisciplinary discussion is really incredibly important to ensuring that patients not only understand what all of their options are, but they're aware of their path early on. So even for patients in whom the intent is to provide systemic therapy after discovery or diagnosis of metastasis after a period of a disease-free interval, I think it's really valuable to have other practitioners involved early on so that they have an idea in their head, if I don't have progressive disease after this period of systemic therapy, then I may be a candidate for local therapy. I think it's part of our role as healthcare providers to make sure that patients are well communicated with regard to the path that they have ahead of them. And you asked about the issue of involving multiple different providers from each type of local therapy early on. And I think it depends a little bit. Of course, with this consensus statement, the recommendation was 3 or fewer lesions. And certainly there are plenty of us who have operated on people with dozens of lesions and managed people with complex lesions. There's a patient who has 8 peripheral nodules that are pretty easy to all wedge out. And there's a patient that may only have 2 nodules, or 3 nodules, but they're all deep within a segment that would require a rather large anatomic resection. And those are situations where I really believe that having that conversation, not after you see the patient, but before you see the patient, when you're prepping for clinic and you see the imaging and you say, geez, it looks like this patient has 2 nodules. One of them will be a pretty easy wedge. The other one, I'm worried, maybe not so easily accessible. Maybe that's a better candidate for SBRT based on its size. Or this one is growing faster, we should take this one out. This one may be one that we can observe, and it would be too small to palpate anyway, and it may be better suited for an ablative therapy once it gets a little bigger. Again, that also depends on whether your approach is going to be open or thoracoscopic or via using the robots, but these are all considerations. So you asked how we do it at Anderson, and of course, every institution is going to be different, but I do feel that to the best of our ability, the extent to which we can involve as many care providers as possible early on. And I do believe that not only includes the medical oncologist for the patient's primary malignancy and the individuals who can provide local therapy to the lung, but also the surgeon who may have operated on the primary lesion in the first place. And so I think it's important, if you're talking about a colorectal metastasis, to involve the colorectal surgeon, and sometimes there's going to be a hepatobiliary surgeon if there's also a liver lesion in these colorectal patients. It may involve the orthopedic surgeon if it's a sarcomatous primary, or potentially a gynecologic oncologist if it's something that's maybe a leiomyosarcoma from the uterus. But involving all of these individuals is really the best way to make sure that we're picking the right time. I mean, these are all questions, because if we wait for the medical oncologist to say, let's give chemotherapy or let's give immunotherapy or whatever it may be, to decide, okay, now I think is the time. What they may not understand is that the location of the tumor, the solid nature of the tumor, all of these aspects can render us to consider it a good time or a bad time to operate on the patient. And even in examples where a tumor becomes particularly cavitary and it's longer palpable, and we've maybe lost a time where surgery may have been easier. In terms of the exact mechanism, I mean, I've talked a lot about timing, trying to get everybody involved early on, but what's the mechanism? Should it be at a tumor board? Should we have an email chain? If you have, HIPAA protected email, should you be using text messages, whatever your telecommunications method is at your institution? There are a variety of different ways, but I really think a wide discussion, including everyone, is ideally the best. I do get on the phone before I meet a patient with their oncologist, with their primary surgeon of the other site of disease. But if I don't have that opportunity, or someone shows up in clinic, or there's a different imaging study that someone else hasn't seen, I tend to find emails to be particularly helpful. We do not present every single one of these patients at our tumor boards, just because there are so many, and that would be, rather arduous, and it would fill up days and days of tumor boards more than we have in a week. But I think for complicated cases, they absolutely do belong at the tumor boards. And, at a lot of institutions, we're aware that, for example, if you have someone with a sarcomatous MET or a colorectal MET, they may end up being presented at the sarcoma tumor board, not the thoracic tumor board. And I think we have to be willing to get up and go to the other tumor boards to discuss these issues with the other specialists in the other areas. But ultimately, the different types of communication are going to be different for every individual. But I think that having that conversation, whether it be via telephone or an email that includes all of the different people who are involved, is really important. And early on, as soon as the pulmonary metastatic disease is diagnosed, that the patient has an idea of what pathway to have ahead of themselves.
Great, thank you. Steve Solomon, do all patients that have pulmonary metastatic disease, should they all get some kind of systemic therapy either before treatment of their local pulmonary disease or afterwards?
I think that's a really difficult question. I don't think we know the right answer to that. And so it's pretty much an opinion, and working with your oncologist, as Mara just said, is how I usually work this question out. I mean, there's all kinds of discussions about cells that are freed, whether it be surgery, ablation, or radiation after a procedure, whether it's helpful to have some kind of adjuvant chemotherapy afterwards is something some people think about. I don't think there's a consensus on exactly whether you need the chemo before, after, where it goes. One of the good things about all of these local therapies, I think we'll get to, is the concept that by taking care of these oligometastatic lesions, we can perhaps get to a point where the patient can take a break from their chemotherapy, a chemotherapy holiday. And when we think about treating the patients and what the end point of treating these patients is, besides things that you're going to talk about later, I know, about survival and everything, I think their quality of life is critical, and giving them a chemotherapy holiday is very meaningful to these patients.
Thank you.
So Bernie, let me just add a little something there. You know, I think that for all of the treatments that we have, it really comes down to this risk-benefit balance. We would certainly consider taking a metastasis out, but if we think that it's going to be highly risky and, patient is, we're not feeling that it's going to be all that much benefit, then, that doesn't look very good. And I think the same applies to chemo. It depends a lot. Are you talking about a tumor that is pretty responsive? Are you talking about third-line chemo where your, response rates are going to be lower? Are you talking about a patient that's already got a, creatinine elevation and, other issues that might make it more risky? So I think those are always the considerations that come into it. How much benefit do we think this treatment might give, and how much of a risk are we taking?
One more thing, Bernie, I'll just say is that I sometimes like, if the chemo, as Frank was saying, is the chemo is really working, let the chemo do its part to make the lesion smaller, which makes it an easier procedure for us. So sometimes if the direction is positive, then make it smaller and we can have a less invasive procedure with a less invasive ablation or some other procedure as well.
Yeah, I think you both touched upon the fact that not all scenarios, not all histologies, not all diseases are the same. So there are wide variety of differences in pulmonary metastatic disease. So that really gets to my next question, which I'm going to ask multiple panelists to answer, but I'm going to start with Andreas Rimner, radiation oncology. Are there any clinical scenarios where you are being asked to consider radiation for pulmonary metastatic disease where you feel hesitation, where you feel like it's not the right scenario for, because as a wise person once commented, if you're a hammer, everything is a nail. And, a lot of times people refer you patients and they're kind of expecting you to take care of it. They think you can do it. What are the scenarios that you hesitate where you're like, well, this is probably not the best way to move forward?
Yeah, I think it depends on a number of factors that are not necessarily radiation specific, just as already was mentioned, but in terms of radiation specific aspects, in principle, there is no site that we cannot treat, but we have to adjust in terms of what fractionation we use, what dose we can safely treat to, and that of course has an effect on how much local control we can expect. However, in a young fit patient that has a very good otherwise good prognosis, has a good life expectancy, great functional status, if a patient was not seen by a surgeon and comes to me directly from the Med-Onc, I will ask the Med-Onc, was surgery considered for such a patient, because they may be in that category of patients that will have a benefit of maybe the additional 5% or so local control that surgery has potentially over radiation therapy, especially if it's a more radio-resistant histology. I had recently a patient where there was a tumor invading a branch of the pulmonary vein. And that is probably a situation where surgical management can probably has an edge in terms of local control, because you can go in there and really make sure you get good margins on it. Plus, there may be at least a theoretical risk that if the tumor responds really well to radiation, that there could be a risk of bleeding. So there are very unique scenarios where I think it's important to consider the other option. And I think it's true for all of us. We all have a hammer, whether that is surgery, stereotactic radiation, or radiofrequency ablation. And it's important for us when someone comes to us to also consider what are the other alternative local treatment options. On the other hand, if it's an 85-year-old patient who has lots of medical comorbidities and a straightforward lesion for stereotactic radiation, there's not much that would stop us from, considering that the appropriate treatment.
So Steve Solomon, one of our webinar attendees asked, related to this topic, is there any type of primary malignancy that you would not consider ablating a isolated set of metastasis for?
So from a histology perspective, I think it's less about the histology for us, but there are many other factors that would make a lesion not really amenable to ablation, and that can be the size of the lesion. I think the larger the size, and I'm talking once you start getting over, let's say 2 and 2.5 centimeters, your success rate goes down, and so that's one reason why it might not be a great lesion for ablation. A second reason might be the location. If it's up against the mediastinum, if it's in the hilum, those are challenging places. So there are a number of reasons why it wouldn't be good, and then there are other reasons that would be good. And the nice thing is when we talk to each other, surgeons, radiation oncologists, and interventional radiologists, we can see where things are good for one, may be harder for others, and that's something that makes it a really in the best interest of the patient.
Great, thank you. So Michael, I mean, when do you say no to a patient as far as surgery? We often see patients and they come and they really are focused on getting all their pulmonary metastatic disease out. And so when do you as a surgeon, kind of say, well, this is not a great scenario for pulmonary metastasectomy?
Yeah, so that's, I think, a multi-step process and evaluation. That is, their physical, clinical status and performance status would be certainly something that would make a surgeon pause if they had bad performance status. But let's say that's okay. Biology of tumor, if someone came to me with multiple melanoma metastases, I would say there are better systemic therapies for now, and we could reserve surgery for something that's perhaps not responsive. So, I think a surgeon has to think about histology, think about what treatments are available for specific histologies, because that should definitely play into it. And we always throw around the number of metastases. So we brought this up now a few times. We all love the oligomet. And so when do you sort of say no if there's 3 or if there's 10? And then when there's 10, I kind of look at the patient performance status, and I always say that age trumps all, in my opinion. The younger the patient, the more aggressive I think you could be, and perhaps the more morbidity you would accept for intervention with surgery. And then of course you think about how much lung would it take to remove all those, and do they have enough capacity for that? And I think that's where you play in with your other colleagues about, okay, we can do some lead resections, we can do perhaps an ablative technique and spare lung. And so you try to really, I think, individualize every case. Clearly 20 pulmonary mets would make you shy away.
So I would add a little something. I think that to me, biology trumps all, and I think in the end, how the patients do is probably more driven by the biology of their tumor than by what we do. We think we make such a difference, and I'm not sure we do as much as we think we do. So, biology to me factors into it a lot. And I think you get a gestalt of the biology from seeing how it, behaves. If you see somebody that has a met that's growing very slowly, you have some idea of that trajectory. If it's somebody where, boy, the number of mets just seems to keep increasing fairly rapidly, you start to think, boy, I don't know if I'm going to get control of this. On the other hand, if they have, even 5 mets or, 8 mets, whatever, but they just slowly are plodding along and growing, and new ones are not showing up, I have more of a sense that, you know, maybe I can achieve something by local therapy. So I think a lot about the biology, perhaps a little bit more than the histology per se. I think the histology plays into that, but it's really, you know, how is this particular individual's biologic, you know, what's the biologic behavior of that tumor?
If I can just jump off of what Dr. Detterbeck said, I would totally agree that biology absolutely trumps all. And when I think about the people whom I've turned away, there's scenarios similar to what you've said where, you know, there may be lesions that are at various ages, various sizes, suggesting that if we can see lesions that are 3 centimeters, 2 centimeters, 5 millimeters, 1 millimeter, there's probably other lesions that are microscopic and we're not seeing on the imaging. And I would say the most common situation where I turn people away, and it's awful to have to do so, but it's folks in whom you plan staged procedures of each side and you finish one side and they come back for their visit between the two sides and you see not only new lesions on the side that you still need to operate on, but potentially even new lesions on the side that you already did operate on. You've already palpated that lung and there was nothing there a few weeks earlier and now there is. And that's just the patient's biology, and it's unfortunate. It's an awful situation, but I think those are the patients in whom we know their biology is such that we aren't helping them. We're actually just hindering them from being able to receive some sort of systemic therapy that can help them better. And that's one of the things that I think is important for patients to hear when you do need to turn them away, is that for us to operate on you, we have to stop your systemic therapy, both beforehand and afterward. And not only might we not help you, we may be hurting you, and your disease may actually blow up during that time that you're off therapy.
Thank
Let me
you.
jump in there. I think conceptually, the goal of any of our local therapies in a systemic disease has to be to render a patient disease-free on a macroscopic level. So at least that's oftentimes what we aim for. So if we can resect or remove all macroscopic disease with local therapies, that is oftentimes what we should strive for. Just resecting or radiating or ablating 1 or 2 lesions when there's others left behind for systemic therapy is oftentimes not meaningful. The other aspect about the biology is that we should consider what systemic therapies are available and their efficacy. That is a rapidly changing field, and we need to adjust to that with our local therapies. And the last point I'd like to make is the distribution. Sometimes you have patients where you have 3 or 4 mets all in one lobe, where it makes a lot of sense to just remove that lobe, and then you can actually render the patient disease-free macroscopically, as opposed to 3 or 4 lesions in all kinds of different lobes bilaterally. I think that's a very different scenario.
Thank you for that. So I'm going to address this question to Frank Detterbeck. Recently, there were published the updated results of the pulmonary metastasectomy and colorectal cancer, or the pulmic trial, suggesting that the assumption that of 0 or poor survival in the control, meaning those treated with systemic therapy alone, no metastasectomy, is invalid, and that the added value of pulmonary metastasectomy towards survival is unknown. Do you feel that that trial, that conclusion is accurate based on the design and execution of the trial? And do you think it provides useful information for all of us to try to decide whether there's a role at all for local control of pulmonary mets?
I think the pulmic trial is definitely an important piece of information that we need to think about carefully. But does it answer all questions? Absolutely not. So just to briefly review, it was pulmonary colorectal cancer metastases, and a large number of patients were registered in the study, but only those much smaller proportion of patients for which there was equipoise about whether to do metastasectomy or to continue some sort of systemic therapy, where they entered in the randomization portion. So, a lot of patients, the decision was they should get metastasectomy. Very small number for which there was equipoise were randomized to either getting a local therapy or getting no local therapy. So, you know, it's a very small group for which there was equipoise. The study included in the end 93 patients, so much smaller number of patients than what they intended. I think that limits it. So small number, selected cohort for which there was equipoise. On the other hand, I think that the one conclusion that stands out quite a bit is, you know, we have always tended to assume that if you didn't do a local therapy, that these patients would fare poorly. And in fact, those patients didn't fare poorly. So I guess you could also say, okay, we've got a select group of patients. There was equipoise for that group. It turns out there was good reason for there to be equipoise because the results were pretty similar whether you did local therapy or not. Does that tell us much about the patients for which there was no equipoise? Not exactly. I think that we do have to I think we have to be careful not to assume that a lack of local therapy is necessarily as bad as we have thought. I think that is something that we should take as a take-home message in our, you know, judgment about when to apply local therapies and what local therapies and how much risk to undertake when you are doing a local therapy.
So, so I guess I'll ask maybe each of the panelists to make to answer this, you know, in some way, shape, or form. So, when we consider therefore local therapy for lung mets, is the primary goal cure, or is there a role for secondary benefits like you know, prolongation of survival as opposed to cure? So maybe we can go around the horn. We would do the ladies first. Mara, Antonoff. Is cure the only thing that matters?
I think that I would most certainly say cure is not the only thing that matters. That's always the ultimate goal, and that's what we strive for. But of course, there are situations where palliation is important. Patients who have hemoptysis from a tumor, you know, eroding into pulmonary artery, whatever else. There are situations where you have a patient who's young, they're healthy, they're in their, you know, maybe their 20s and their 30s, they've got a young family, and they've got 10 lesions that are stable on systemic therapy, but for some reason, one lesion is continuing to grow at a rapid rate. You're not going to cure that patient by taking out that one lesion that's growing at a rapid rate, but it certainly makes us feel better, like we're doing something to prolong that patient's life. And like we've discussed already so many times, it's individualized, right? So, I mean, what's the risk-benefit ratio for that exact patient? But I'd love to hear what the other panelists have to say as well.
Okay, Andreas Rimner.
I think there is increasing evidence that we can achieve a progression-free survival benefit. There were three phase 2 randomized trials on SBRT versus continuation of systemic therapy or palliative therapy that showed a remarkably similar outcome in PFS benefit of about 6 months. That was, 2 of these were in non-small cell lung cancer, oligometastatic patients, and 1 was in all kinds of different histologies. So that's, I would say, the best evidence we have right now, indicating that there is a PFS benefit to what we do with local therapies, obviously in the rightly selected patients and all that. And then there's an ongoing phase 3 NRG-LU002 study that is looking at this and then powered a little bit more strongly. So I do think PFS does matter. For instance, in EGFR mutant lung cancer, we've seen an over 2-year duration before we need to switch to another systemic therapy with the addition of local therapy, surgery, and radiation, and ablation as well. So, you know, those are meaningful time frames, I believe. So yes, we have some evidence now that I think the surgeons can glean from, given that there's plenty of data that suggests that both surgery and SBRT result in local control of about 90%. I think, you know, even though we don't have maybe pure surgical data as much, other than the pulmic trial, there is certainly data for local therapy in that space.
Great. Steve, Solomon?
Yeah, I mean, I would say what I said earlier is I think giving patients the chance to get off their chemotherapy is a very good quality of life measure. And then secondly, as Andreas alluded to, the oncologist has limited drugs, and so if you can have them, if you can buy time before they have to switch to a different therapy, that also provides benefit. So I think there are reasons that are not beyond just the survival where we can help patients.
So Mike Lanuti, how would we get that notion to, let's say, a larger group of perhaps medical oncologists that have equipoise or not about the value of aggressive local therapy for pulmonary mets? How do we talk to our medical colleagues about that, or provide evidence, or, I mean, assuming you believe there's benefit beyond just cure or not cure?
Well, I think we have to be present at the multidisciplinary meetings and bring in the evidence that we might have accumulated. Again, none of it's terribly randomized. I think that if they understand what we offer has low morbidity, where there's good functional outcomes, I think they'll buy into that. If they realize that, as Steve said, if they can get holidays off their chemotherapy with a hiatus where you're taking out some things surgically that for us is low morbidity, I think that adds a lot of value. And in my discussions with the patients, I don't often always say, okay, as my first sentence, we're going for cure. I say, can this be safely removed without, making you a functional cripple? And that's, I think, important for us. But when you ask, how do we get the medical oncologist on board for local therapies? It's having all these people on this call in the room together to discuss what can I offer with low morbidity.
Excellent. In the interest of time, I'm going to turn it back over to Dirk to take us home with maybe some discussion comparing all the modalities a little bit.
Thanks, Bernie. That was a good discussion. I enjoyed it. Yes, now we have come to the discussion on comparing different modalities, and we are very lucky that we have both an interventional radiologist and a radiation oncologist, and of course, many surgeons. So my first question would be, for those patients that can tolerate any local therapy, which scenarios do you think are best for ablation, for stereotactic radiotherapy, and for surgery? So maybe let's start with ablation, and I turn it over to Steve. What are, in your opinion, the best scenarios?
I think we have to work together as a team. I think we have to realize that we need to preserve lung function. I mean, what's in the best interest of the patient is preserving their lung function and quality of life in unfortunately, oftentimes a terminal disease. And so we have to work together and say, some are good for one modality and some are good for another modality. As I started to say earlier, the smaller lesions tend to be good for an ablation. A central lesion where a surgeon would have to do a lobectomy, again, doesn't preserve as much lung. And we also have to keep in mind that these patients are likely to have multiple metastases even after this first intervention. There may be a second intervention and a third intervention, and we don't want to waste it all up front. And if it's, if you irradiate the, entire right chest, you're not going to be able to irradiate them the second time when ablation might not be possible or surgery may not be possible. So we have to think ahead of time also and work together as a team.
Okay. So should we then all be in the same multidisciplinary board meeting?
We have, and in fact, we have actually started that here in different modalities. We have, for example, a multidisciplinary bone metastasis clinic that actually has been very productive, where we have a radiation oncologist, orthopedic surgeon, and an interventional radiologist talking about these patients. And it might be time that we think about this too for this oligometastatic lung lesion as well.
Good. Let's turn over to Andreas. What is your opinion on the best scenario?
Well, for radiation, it is generally the patient that has too many comorbidities to be a good surgical candidate. I think that is still the patient population that we're most focused on. As you know from the lung cancer literature, there's certainly, it has become the standard of care for inoperable patients, and for marginally operable patients and operable patients, it's still, a little bit of a discussion. It's probably very close, but not standard. Now, in the metastatic setting, I often feel a little bit more strongly about radiation, depending on what the context is, and that relates to what Steve just said, that we have to think about what else is coming down the road, right? If the patient has more metastases, if the patient requires more local therapies, what is the least intrusive and can reserve most lung function. And just by default, because radiation is generally considered in the patients that have poor lung function, we are specialized in those patients. But again, as I said earlier, if it's a young fit patient, I will, with really only 1 or 2 metastases, I think those are best served with surgery.
Okay. And then finally, let's turn over to the surgeon. Frank, do you think that a fit patient should have surgery first before we discuss other ablative treatments?
Well, I am reflecting on the fact that when I was 20 years old, I thought I knew a lot of things. And each year I come to the conclusion that I know less and less. What I thought I knew, I don't really know. So I'll start with that. So, I used to think a lot more about cure of patients. I'm a lot less convinced that that is really what we are accomplishing. I think we are often just selecting those patients that are going to have a really long disease-free interval, and so I'm a little bit less sure about that. As I have become a little less sure of that, I've sort of moved away from saying I really want to palpate the lung and get every last little speck out of there. I'm more willing to say, well, I'll take out what I see, and we'll see what happens afterwards. I think that along these same lines, I am much more cognizant of the I think primarily short-term morbidity of surgery, but there certainly is a downside, and that makes me be much more how should I say, it doesn't take that much to sway me to doing radiation or ablative techniques. I think if it's something that is a chip shot for surgery, I think that's still nice and definitive, and it's done. And patients are often a little worried with ablative techniques. Well, how do I know it's really gone? Has that appeal? That's a psychological thing. I think sometimes there's value in getting more tissue. So I think that can be something that moves you towards surgery. But like I said, I think that I'm a little bit, I'm more influenced by the gestalt of the biology that I get. I'm more influenced by thinking about the morbidity that I'm creating, and I'm less convinced of the, benefit that local therapies have in general, but also that, surgery has over other modalities. So I think that sums up my general sort of shift over the years.
Okay, that's excellent, Frank. Thank you. Now, time is running, so let's move to the topic of lymph node involvement. We know from studies that a certain percentage, up to 15% of patients with pulmonary metastases will have lymph nodes involved with cancer. And so the question, of course, to the panelists are, do we need to sample these lymph nodes? Do we need to do a radical lymphadenectomy in all patients? And how do our radiation oncologists and interventional radiologists deal with the lymph nodes, because they cannot sample these lymph nodes? So what is your opinion? Let's start with Mara, maybe.
Sure. It's a great question. And I think that many of us were taught not to take out the lymph nodes because it doesn't improve survival. But as has been alluded to by several of the panelists already, is that we do believe that there's a really important piece of prognostic information that we get from taking out those lymph nodes. And from my perspective, if I think I'm going in to take out 2 or 3 nodules and that the patient is going to be disease-free, and I don't get any information about the lymph nodes when I'm right there, and it's pretty darn easy to take those nodes out. If I can take out a whole bunch of nodes and be able to give information to the patient, their medical oncologist, and the other treating physicians, just to be able to have an idea what their disease state is, it may impact decisions down the line for that patient about whether they feel systemic therapy is appropriate. And so I feel that for a lot of patients, they don't know if there's going to need to be further systemic therapy after surgery. And we frequently tell them that it depends on intraoperative findings. Sometimes you go in looking for 1 nodule and you take out 5. Sometimes you go in to take out 1 large nodule and you also find a bunch of positive lymph nodes. So I think we are there. It is in our skill set. It is not technically challenging. And there's really minimal reason not to provide that additional prognostic information to the rest of the care team while we're there.
Okay, thanks. Steve, how do you deal with the lymph nodes that show up on the PET scan or that do not show up on the PET scan?
I think let's take the ones that don't show up on the PET scan first and just talk about that, I guess. I mean, the need to sample nodes that are not large or active on a PET scan, for me, that can't sample them because I'm there like Mara, I don't, to me, it's not critical. I mean, it's something we don't see. It's like saying that the circulating tumor cells, I mean, in the blood are there, but we don't see them, and I'm just going to move on without that. So if I don't see lymph nodes that enlarged or FDG avid, I sort of move on and say, we'll just treat the lung nodules. If they become large or avid later, we'll deal with that later. If I start out with a patient who has those, then it's a different story. It may mean that makes somebody more likely to go to surgery instead of an ablative approach.
Okay, and Andreas, how do you deal with lymph nodes?
The bottom line is we don't really, right? I mean, we rely on good imaging, and that is key, I think, before we plan the radiation. Get an up-to-date scan, CT scan or PET scan, depending on the primary histology, if it's FDG avid. I think from a non-surgical perspective, PET scan is not as bad as it is sometimes amongst surgeons. I mean, the sensitivity is around 90%, so yes, you miss maybe 10% or maybe 15% of the lymph nodes, but especially in a metastatic setting where it's not necessarily a curative setting, I think that is of less importance or value. I think we have much more reason to fight over that in a definitive curative early stage lung cancer setting. But and even there, we just go with best imaging many times when patients are not candidates for invasive mediastinal staging. So I think the bottom line is PET scanning is not that bad, and yeah, in radiation oncology we just don't deal with the lymph nodes. That is a very.
Then my final question to the same 3 panelists. Do you know of any situations when multiple local modalities are combined? I mean, we start with surgery and then we move to stereotactic radiotherapy. What are these situations?
We've been involved in a number of cases like that, where one lesion in the right lung might be very large for an ablation, and the surgeon would take that out, where there may be smaller lesions on the left lung that I could ablate, a central lesion that the radiation oncologist could potentially do. And that's how we can work as a team.
Okay. Good, that was excellent. Let's turn over back to Bernie. Maybe you can, Bernie, discuss the future directions and make some concluding remarks.
Yes, thank you. Again, I wanted to thank all the panelists. It was really a great discussion. The hour really flew quite by. We could probably talk for hours about this topic. I think overall, it's clear that there is certainly a role for treatment of local treatment of pulmonary metastatic disease, but clearly it requires a thoughtful sort of disciplinary decision-making process, because there's so many factors involved, including the histology of the disease, the natural history of the disease, what the patient brings to the table, the location and size of the lesions. So it really requires all of these types of excellent physicians, and including the most important, the patient, to decide how their treatment fits best in their goals, whether it be the opportunity for cure or the opportunity for prolongation of survival. So I do think we definitely need more information, more guidance, and probably seems to me that that would come through really a multi-modality effort to try to, again, define these kinds of guidelines and, for people to treat these patients. So I think there's still a lot of unanswered questions. I do think it is going to require more work in the future. But I think that this was a great webinar to kind of discuss sort of the most important points and goals of local treatment in the lung. So on behalf of the STS and my fellow panelists and my fellow moderator, I just wanted to thank everybody for participating and wish everybody stays safe, and look forward to some of the other seminars going on this summer by the STS.
Thank you.
Thank you.
Thank you, Dr. Park and Dr. van Raemdonck, and thank you to all our panelists today for your participation and insight. A reminder that the archived version of this webinar will be available tomorrow at sts.org, as well as on the STS YouTube channel and on the STS Surgical Hot Topics podcast. Once again, we'd like to thank Medtronic for their support of this webinar series. We hope you'll join us on Thursday, August 13th at 5 p.m. Central Time for the next webinar in our summer series. Thank you all again, and hope to see you back here later this month.